Good afternoon, everyone, and welcome to our webinar. My name is Ashley Moore, and I'm the Vice President of Marketing for Metaball. In today's presentation, Matt Savelle will discuss how to run your practice by the numbers. Now I'll let our expert take over the presentation. Matt?
Thanks, Ashley. Appreciate the intro there. If you definitely have questions, please submit them throughout the webinar, and we'll do our best to get to them. As Ashley mentioned, if we can't, we'll certainly follow up with you after the fact. Just quick background on me. I joined Metaball full-time in January. I currently run business development and marketing for the organization. Prior to that, I helped develop and install the analytics platform on top of our practice management system. My career has been primarily in healthcare software services and advisory consulting roles. And I'm excited to share some insights today in terms of measuring to improve and how you use metrics and what metrics to be looking at to know whether our revenue cycle is in tuned or not. A little bit about Metaball. We're a privately owned corporation. We've been around since '98. We're headquartered in Little Rock, Arkansas. I'm actually located in San Diego. About 104 US-based employees. We've got clients in 46 of the lower 48. We did about close to 3 billion in healthcare transactions last year with our technology, and measure to improve is really a philosophy that we've adopted at Metaball. You know, when I started my consulting career, I started with a company called Stockamp and Associates back in 2000, and one of the things Dale Stockamp was steadfast on was the concept of measure to improve. And if you can't measure it, you can't manage it, you can't improve off of it. And that's something that we've invested a lot of time, energy, and money to make sure that we have the insights and the technology tools to understand whether we're doing a good job on behalf of our clients and making sure our clients have software that allows them to run their practices more efficiently. A couple housekeeping items. We're going to talk a little bit about why billing metrics matter. Then we'll get into specifically a handful that I think are important to watch and why, and then we'll close the webinar out. I'm hoping to get done in about 35 to 40 minutes, and we'll have some time for questions and answers. So why do the billing metrics matter? You know, I like to use this slide because it helps me understand that, you know, when you're in a big city, you know, like New York or Philly or San Francisco, and if you don't have, you know, a GPS, even if you do have a GPS, it may tell you where you're located, but it doesn't tell you what's around the corner. You know, would you make different decisions if you knew there was a mugger around the corner that was going to take your money, or if there was maybe a leprechaun around the corner that was going to give you a pot of gold, right? Would there be different decisions that you make? And so one of the things that I'm very steadfast on is that you've got to be able to know the pulse of the organization at any given time. You got to make sure you have metrics aligned that tell you whether you're on or off target. It's too important to protect your revenue in today's market. We're going to get into some of the market trends here, and many of which you all are aware of and you're battling every day, but it's important to protect and collect every dollar in good revenue that you have. Measuring success is something you'll hear me bring up consistently throughout the day. You know, it pays to be a winner. You know, I've got a couple of friends in the SEAL teams, and that's their mantra. It pays to be a winner. Well, it definitely pays to be a winner. And if you have data to show you're a winner, you can build the reverence that you deserve. You know, Berkshire Hathaway, you know, is definitely a winner. It's proven. If you think of Warren Buffett and how he manages his investments, you know, the amount of time and energy that go into looking at the operations and making sure he really understands what he's buying. He's not just buying on volume or hope. You know, he's really making strategic buys, and obviously his portfolio shows that. No different in healthcare. Margin, you know, one of the things that we've focused on as a company is margin. I think a lot of, you know, healthcare over the years is, you know, there's gross revenue, there's net revenue, but at the end of the day, you don't control a lot of that stuff, right? Payer mixes change, reimbursement rates change, reimbursement models change, regulatory implications come at us left and right. So what we can do, though, is we can make sure we're maximizing our collection of every dollar in good revenue. We can manage cost, but if we look at the way the market's treating us, is that over time that margin's getting harder and harder to deliver on, which makes it even more imperative to run your business as efficient as possible. You know, so that you can you know, deliver the service that you need to the community at a cost that allows you to still run a business. We're really running businesses now in healthcare, whereas for many years, we didn't have to really think about it that way, but now we do. It's a completely shifted consumer model, and it's only going to get more consumer focused. I put the patient collection challenges. We've done some webinars, and we'll continue to do some more this year around just patient balances in general, collections, pre-collect initiatives, et cetera. But this is really telling. I mean, if you think about that dollar that you're billing, the dollar you bill today, even for a commercially insured patient, is going to be different than the dollar you billed 10 years ago. If we look at a study that came out in Forbes, in 2000, provider income was only represented 5% from patients. So patients basically accounted for 5% of that income in 2000. Today, it's 35%. The rumor on the street is it could be as high as 50 to 55% over the next 5 years. So the consumer it needs to be a large part of your model as you start looking at metrics, and you start looking at your AR, and you start looking at self-pay. If you're aging self-pay balances and you don't have a good strategy in place to reduce that age AR and start to collect that at the point or prior to service, then you're definitely behind the ball, and you've got to remedy that. If you look at self-pay in 2016, patients true self-pay paid 6 cents on the dollar. Pretty tough to run a business when you're getting 6 cents on the dollar. Even Medi-Cal out here pays better than that. Patients paid only 15% of their balances after the insurance paid. So even for the insured patients, we're still not getting 100% of that patient liability after insurance is paid. Debt continues to rise. Medical debt. I always use the analogy. If you got the utility bill or your healthcare bill, what are you going to pay first? If you got to buy groceries or healthcare, what are you going to pay for first? So medical debt continues to be kind of put to the sideline, which makes it difficult, for us to run businesses, especially in the specialty market, where there's a lot of elective procedures. Got to really start treating this like a business. And then if you look at just this is always alarming to me. If you look at patients that have bills less than $500, 68% of them did not pay their balance within a year. So again, I can't walk into a store and buy an apple and say, I'll give you half of it now and I'll give you the other half a year from now. We've got to start changing the way that we operate in the growing consumer model here. So what are some of the vital signs we'll look at? Obviously you've got lots of data. When I think of my career in 2000, we were doing dashboards and Excel spreadsheets. We were lucky to update them monthly. It was very manual, time consuming. Well, things have changed. I built an analytics company in 2007. I sold that to Streamline Health in 2011. I've been inundated with lots of data visualization companies. There's lots of cool technologies out there that sit on top of your systems. We actually developed one ourselves internally so that we could get access to information. But the bottom line is your access to data today is way better than it was 10 years ago. And it's continuing to get better and better. But access to data is one thing. Data visualization is one thing. Knowing what to look for, and then more importantly, what to do when you start to see what the numbers are telling you, that's the more difficult part. So some metrics that stand out to me, looking at your AR is very important. I like to look at percentage of AR over 60. You could look at it under 60. Days in AR gives you a good idea of how quickly you're getting paid, helps you plan. Average collections per visit helps you understand, are you improving? Do you need to start looking at the procedures you're doing? Do you need to look at the contracts and how you negotiate with your payers? Do you start looking at your payer mix? Do you start market different? Do you look at referral sources differently? So average collections per visit can be a very good metric to look at for a lot of reasons, and we'll get into that shortly. First pass resolution rate is a great one, right? A lot of people talk about clean claim pass rate, but a clean claim that goes out and then gets denied and comes back is not clean. So, making sure that you understand how many claims are actually leaving the building, getting paid without any further effort is important, and managing your processes to that is important. Contractual variance is another one. Most people have fee schedules. We understand the ERA allowed amount that comes back from the payer, being able to look at your fee schedule allowed versus what the ERA says, and is there a variance? Underpayments are not going to go away. You got to be able to identify those underpayments quickly, see if there's patterns and trends, and then go after that money because it's yours. GCR and NCR are important. Your gross collection rate gives you an idea of how much you're collecting on every dollar billed, and net collection rate gives you an idea of how true you are at collecting what you're owed. And there's going to be deductions, that you have to look at around bad debt, charity care, administrative write-offs, and denials. But those are both good measures to see how you're doing. All right, so let's talk about AR. So charges older than 60 days. People ask me like, well, what's the benchmark? I mean, if I go and I look at an ATB for insurance, for example, only if I exclude patient liability, if you've got about 80% or more in those first 60 days, you're doing really well. When you start looking at the patient balances, that obviously starts to inflate that number. But when you start to see the percentage of AR over 60 days start to go up, higher and higher and higher, 25, 30, 35%, you really need to start looking at what are some of the issues that are preventing you from getting paid timely. So it could be charge lag issues. How long is it taking you to get the charge slips from the physicians or through the EMR into the billing system and out the door, right? It could be you're getting a lot of charges going in, but you're getting a lot of rejections and edits. You're hitting edits in your claim scrubber. So, why is that? Do we need to improve the claim scrubber? Are there things that we can do on the front end to get those claims clean and out the door? Looking at first pass denials, when you do get a denial and that ANSI code comes back, what do you have? What tools do you have to know what you're being denied for and why? Can you improve process to prevent that? Looking at things around inappropriate write-offs, making sure that people are taking the adjustments timely, and accurately. So lots of, just overall challenges can add to that. There's, payer mix is a factor. We have clients who have large worker comp payer mix, so obviously it's going to be harder to collect on those. But overall, if you're, have a good solid payer mix between, Medicare and commercial managed care, about 80% should be in that first 60 days. Just to show you kind of an idea here of making sure you're kind of looking at your insurance AR versus your patient AR. On the insurance side, we talked about 80–85%. On the patient side, it's a different story. You definitely want to start looking at your patient receivable. Those statistics I talked about earlier are real. And if you're carrying, like in this example, close to $1 million in patient liability out there, you can collect, statistically, you can collect about 15%. I mean, that's a horrible statistic, but unfortunately, it's true. And we've actually seen this in reality for some of our clients where we are going after the older balances. You're lucky to get 15, sometimes 20% on that debt. So what are you doing to estimate the liability prior to the service, collecting prior to the service, at the worst case scenario, collecting at the time of service? We even have some clients now that won't schedule patients for visits if they still carry a balance out there. So you've got to get more aggressive with how you treat the patient AR, because obviously that patient AR is going to make up a larger portion of your overall AR today than it did 10 years ago. So that's a big component to keeping your AR over 60 days reasonable. In terms of workflow, making sure your business offices are set up, you're stratifying not just by balance, but based on, estimated cash yield. You have the fee schedule, what you should collect on these charges. So sort your work list that way. Make sure that people are prioritizing appropriately to generate the biggest bang for the buck on their work effort. That's how we run our RCM business internally. Monitoring those first pass denials, I cannot preach enough about that. Is that so many times we just let these denials come back and no one really looks at them. We've actually had in our own company developed a mapping of ANSI codes to classifications of denials, so you quickly know what's a COB denial versus coding charge entry versus additional information requested, and then you can drill down quickly to see why is this stuff happening. That's going to help you really fix process, look at your organization structure on the front end or the middle part of the revenue cycle to help get these clean claims out clean the first time and get paid. We talked about patient liability, auto dialers for sure. If you're making outbound phone calls with a human, don't waste your time. You got to use an auto dialer. Just to give you a statistic, the dialer we use, we could put in 1,000 calls a day with the computer, 10% connect rate. So 10% of people see that phone number and actually answer the phone. Of that, 10 to 12% will be the person you need to talk to, right? The guarantor or the person that owes the money. And of that, 10 to 15% make a payment. So you start thinking about the FTE cost of staffing people in the business office to make outbound calls. No, don't waste your time. Definitely get a dialer in there or find a company that can do that for you. And then I would just say the last one is just looking at what your AR collectors are doing. When I was a consultant, I was always amazed at the times I'd go into a business office, and I did a lot of consulting on the hospital and large employed physician groups. And it didn't matter really which side of the equation I was on. I would start talking to the follow-up ropes, and I'd say, hey, well, what do you do, other than call on insurance, claims, et cetera? Well, I take phone calls, and then I do this, and on Wednesdays I do that, and then there's 10 minutes here I do this. And next thing you know, you're like, wow, you got a lot of priorities going on here other than just collecting AR. So if you can get all those other duties as assigned to different people within the organization and let your collectors really focus on what they should be, which is collecting receivable, overturning denials, you're going to be much happier down the road. So enough on AR, sort of. We'll talk about AR days here shortly. So days in AR, it's funny, when I started my career, I'd walk into these organizations and it'd be 120 days, minimum 120 days. And we'd get someone to like 60 or 70 days, and there'd be a big balance sheet improvement and a lot of cash acceleration, and the C-suite would be very happy. Nowadays, with all the electronic submission and all the utility that we've gained through technology, I'm lucky to walk into a place that's less than, or it was more than 50. 50 is odd. I see a lot of folks in the 20s and 30s. So I don't really have an overall number for you. I mean, you have to look at a lot of factors when you look at days in AR, but if you look at your total outstanding receivable and you divide it by an average daily gross charge number, I mean, that gives you an idea of where your AR is, and just making sure that, you got to factor in if you're 3-4 times the Medicare fee schedule in terms of your allowed amounts, if your gross charges are super inflated, that obviously can skew the number. So you got to keep those things in mind. But AR days is still a good metric just to see how quickly you are turning over your receivable. And we use it internally, obviously, to make sure that we've got cash flow to pay for all the other things that we're doing and delivering as a company. So it's definitely something to look at. If you're looking at days in AR on the patient side, again, we've kind of talked about this, so I won't bore you. But you've got to start looking at what you're collecting prior to the service and then what you're collecting after. So you should have analytics in place that can tell you, I collect 46% of my patient liability, prior to the date of service. Or if you're collecting 25%, 60 days after the date of service, that's a problem. Like, how do I accelerate that? What can I put in place on the engagement side? Do I need to do mobile outreach, email outreach, put a computer system to auto dial? Do I need to, change the way my letters are written? Do I need to look at a different statement vendor, right? So there's things that you can do to decrease the days in receivable for the patient today. I think that there's definitely some things in place on the front end that impact your ability to get paid accurately and timely. I look at like the eligibility, verifying demographics, making sure that the patient still has the same insurance, they still live at the address on file. Like, these things all slow down. If those are wrong, that you're going to send the claims to the wrong insurance, you're going to get a denial. Hopefully they didn't need an authorization on that service, or you're in trouble. If you're got a bad addresses, I recently met with a prospect who 22% of the mail that went out got returned. So you start thinking about a cost there. I mean, the cost associated with just bad demographics, and then the delay in getting reimbursement. And then if you don't have a good skip tracing program in place, how do you ever track down the right information from the patients, right? So moving a lot of those activities up front, making sure everything is buttoned up as possible. For those of you that are in the non-hospital space, these are not emergent visits, right? I mean, I don't walk into a orthopedic practice and say, I have to get my shoulder fixed today, right? If that's an issue, I would go to an ER and be diagnosed. So we have time to do these things prior to service. Let's make sure we're doing them consistently. When we look at collections per visit, this is, there are lots of benchmarks out there. There's a couple companies that we work with to look at these types of statistics, understand, based on the region, based on the type of specialty you are, type of procedures you do. I mean, what should you expect, in terms of this? There's definitely ways at which you can look at why this is depleting. If you start to see your collections per visit go down, right? I mean, as long as it's not avoidable deductions to charges, and by that I mean, denials that should have been overturned that weren't, bad debt write-offs, charity care, if that's something your organization does. And then I call the unknown bucket is the administrative write-offs. It's the other, right? So, as long as those buckets are in control and you know that, you have a handle on that, you should be able to see consistent reimbursement per visit. Now, other variables you have to look at is your payer mix. Is your payer mix changing? Am I seeing more Medicare today than I did, 3 months ago, 6 months ago? You've got to look at your procedure mix, right? So if I'm doing different procedures that historically are paying me less because it's the way the fee schedule is aligned, then I have to start looking at that. So again, you got to have access to data to back up, and research what you see when you're looking at any of these metrics that I'm talking about today, right? If you start to see a trend going down in collections per visit, you got to be able to quickly get at your data to understand the why, right? And it doesn't do any good to say, hey, my charges per visit are going down. I hope it goes back up. That's how businesses go out of business, right? You've got to get more proactive. You got to have the technology in place. I know many of you do, to go after the data and understand why things are happening. I think that, how do you improve your collections per visit? I keep harboring on self-pay, but you just saw that self-pay is becoming a large payer here, right? It's the third payer, highest payer now, next to Medicare and Medicaid. You got to get that money. You've got to estimate and collect that money prior to the service, or any minimum at the point of service. Do not let that stuff age. If you're in the elective procedure market, folks know if I have a commercial managed care plan, I know I'm going to pay 10%. I know it going into it. So that's fine. You have to educate me. At times you have to, give me some options to pay. I think we see a lot of folks that will do prompt pay discounts, as long as it's in line with their contracts. You can offer very good payment plans. You can offer care credit and, access to other financial models, and as you see fit. But it's definitely something that will help increase that collections per visit as the overall payer mix is changing just inevitably. So let's talk a little bit about first pass FPRR. Say that fast 10 times, it's difficult. But this is definitely something that we look at religiously. We are trying to make sure that when we're working receivable on behalf of our clients, that we're maximizing our ability to get these claims out clean, right? And we've got objective data that we use to talk with our clients to say, when things aren't going out clean, these are the areas that you could help improve that will help get these claims out clean. So it's imperative to have a good EDI system. You've got to have the ability to get at the data within the EDI system, right? If you have a billing editor, but you can't get good data and you can't drill down quickly, it's not going to really help you understand why things are getting hung up. We talked about first class denials. If you're not getting paid, if they're going out the door but you're not getting paid, you have to build that into the narrative, right? So you get a charge that got onto a claim and a claim that got through the EDI and out the door, but it got denied from the payer. So there's your narrative. Then the question is why? Why are these things happening? And that's going to help obviously reduce your days in AR, reduce your overall AR. It's going to improve your net revenue because a lot of the stuff is not going to have to be followed up on. So you've got to focus up front on this, but make sure you have access to good reporting coming out of your billing system. Clean claim pass rates, we like to see greater than 90%. I mean, I think that, at this day and age, 95% is really 90 to 95%, you're doing pretty well. When you start to go south of that, though, you really do have to understand real why, and you have to, really objectively look at areas in your process. Are there things that you're doing on the coding front? Are there things you're doing on the charge entry front? What are the reasons why, I can't get these claims out the door quickly? A lot of our clients will have dedicated auditors, where they'll actually audit these charts before they go out. So they're looking at not only charge capture, making sure that everything in the physician transcription narrative actually gets onto the claim, but actually making sure that the claim is appropriate based on the service that was rendered, and the coding is appropriate, the modifiers are used appropriately, et cetera. And that also will help. So it's an investment for a clinic to staff someone to do that. But for certain clinics, it may be worth it, if you have trouble getting claims out cleanly. Most importantly is that you identify improvement areas, fix them, but then measure going forward, right? Nothing worse than saying, hey, I found an opportunity, I figured out what was wrong, I fixed it, and then you stop looking at it, and 3 months later, that thing came back. You know, we used to always joke in the consulting world because they'd bring us on site. We'd implement all this technology, services, redesign people, process. We'd put dashboards in place, and then we'd leave. And 6 to 12 months later, we would be right back at the same client doing the same thing. And why is that? Because people stopped measuring to improve. They stopped looking at this stuff. You know, they just assumed. An assumption does not work in business anymore. It does not work in healthcare. Do not assume. I think, you know, when you look at the benefits of eligibility gas, there's lots of great tools out there. I mean, we offer batch eligibility. We've got real-time, you know, eligibility. I mean, there's no reason it takes 6 seconds to return a gap. You know, there's good skip tracing tools out there to make sure that, you know, the patient lives where they say they live. So there's technologies that exist, but making sure that you've got this process in place before the patient shows up. Or if you're in the urgent care market, you know, you're doing it fairly quickly, you know, after the visit, or even during, you know, prior to the visit, depending on the situation. But making sure that they've got it, and that you're able to understand, you know, how much, you know, what the benefits are, making sure that you're able to prevent timely filing denials, making sure that you're ready to prevent, you know, bad debt, right? I mean, if you got bad addresses like that one client I was telling you about, it's hard. I mean, if patients move 5 times, you can't find them. They're not even going to know they owe anything. And a lot of us don't proactively think, well, hey, there was that one visit last year. I don't think I've received a bill yet. I should follow up with them. I don't think we're there yet on the healthcare side. If anything, we're on the opposite. We're like, I hope they don't send me that bill, or maybe they forgot about me, right? So, anyways, it's important to do all that stuff. And at the end of the day, I mean, the patients, for the most part, especially in the elective procedure market, I mean, they don't want to have all this stuff happen. I mean, the worst case scenario is you end up sending a claim to the wrong payer, you get a denial or rejection, you send it to the wrong address, and then they end up in collections. And I've seen it happen time and time again. And so making sure you get everything done right up front is so important. And it does impact patient satisfaction, even though they may not be the most proactive at giving you the new insurance card and the new address they live at. You know, we definitely, the consumer's always right model continues in healthcare. So we've got to push them on that. Contractual variances, I can't speak enough about this. It's, you know, you spend a lot of time negotiating with the insurance companies. You know, Medicare is nice. They just kind of put it out there for you. That's what you're going to get, like it, right? But the commercial insurances, you do have an opportunity to negotiate with them. How do you know you're being paid correctly? You know, first of all, you got to make sure those fee schedules are loaded in your practice management system. You just have to. I mean, if you're on a PM and you can't load a fee schedule, and you don't have analytics behind that data to tell you whether you're being paid appropriately, you're losing. You're definitely losing. So get your fee schedules loaded, make sure they're accurate, and in the PM, and then make sure that you understand your contracts. You understand, you know, the last time you negotiated, you know, are you starting to see underpayment trends? You know, and we'll talk a little bit about that. But you know, if you're being underpaid, you know, you have the ability to go back to the payer. You know, a lot of times if you're being underpaid on one item, you know, that could be a systemic problem across multiple payers. So being able to go back and show a payer real data always helps with the discussion versus being subjective. You know, if you can objectively tell an insurance company, you know, this is the procedure I continue to do, this is the allowable amount that we negotiated with you, and this is what you keep sending me back on the remit and paying me, what's the deal? So have data, bring it to your meetings, it goes a long way. If you look at the analytics side, you know, you've got to have an ability to quickly, you know, trying to go claim by claim does not work. You know, you've got to have a way to say, okay, at a high level, where do I potentially have an underpayment opportunity, right? And that's going to be imperative. So analytics obviously becomes a factor there, and I'll show you a chart here in a second. You know, the way we calculate variance is, you know, your contracted rate minus the ERA allowed amount, right? And where there's variance there, and then we sometimes go a step further and we'll compare that the actual insurance money that's been collected and see how that compares as well. So just some high level, you know, graphics here, you know, being able to look at, you know, say service dates over time, you know, dark purple, you know, there's a variance there, click on one of those months, you know, for example, in January of 17, now I want to see it by payer, you know, so now I want to say, okay, maybe for Blue Cross Blue Shield, I want to look at that variance there. So click on that, takes it down to the line item, charge level. You got to be able to get at this stuff pretty quickly, you know, and then you got to be able to see the patterns pretty quickly. But look at the CPT categories, right? Look at the, are there trends based on the procedure? Are the fee schedules loaded incorrectly? I mean, that's something too, right? I mean, you start to see variance and you realize, well, it's not really a variance, it's just the fee schedule is not pointing correctly to the charge. So that's a problem. So it can also be a good QA tool for you as well. All right, let me see on time, 12:30. Okay, GCR. Gross collection rate, I still like looking at it. I mean, I think, you have to obviously take into consideration your charge structure, right? I mean, I was talking with a dermatology practice yesterday who they know that they have super inflated charges. So, whereas I was talking to another one of ours that runs, 50, 55%. So every dollar they bill out, they're getting about 55% back in money, combination of patient and insurance, whereas the group I was talking to yesterday just knows right out of the gate they're going to be under 40. Okay, so you have an idea based on your total charges and your charge master where you're going to fall. But it's important to see, because if that number consistently starts going down, if you're running 40, 45%, and, based on your payer mix and based on your fee schedules, and you start to see it drop around 38, 35, 32, that starts to give you a warning there, like, wait a minute, either my payer mix just shifted incredibly strong in the wrong direction, my procedure mix is changing, or I'm starting to have delays or zero pays, delays in reimbursement or zero pays, right? So I'm having an increase in denials, an increase in bad debt charity, and administrative write-offs. So when you have those deductions to gross charges that aren't contractuals, that can be a red flag as to why your GCR is going down. So you definitely want to look at, total payments divided by total charges, multiplied by 100%, so you can see what that runs. People ask me, like, how do I know I'm doing well? I can't tell you that. I mean, a lot of it depends on your charge, what you're charging. It depends on your payer mix. I mean, when I was doing consulting in California, for example, right, with hospitals here in California, I mean, I was seeing Medi-Cal GCRs at 9%, but that's because these hospitals were charging, $1,000 a Band-Aid. So it just depends on where you're at. Most importantly with GCR is that you have it trended over time, so you can start to see, is it improving over time? Is it declining over time? If you start seeing a decline, you need to be able to start analyzing the reasons why, okay? And that kind of goes into the net collection rate, which is looking at, how well are you collecting the expected net revenue, right? So you're looking at your charges less your contractual allowances, right? And that should be in line with what you're getting in total payments. So that would be your insurance plus your patient. Benchmark is between 96, 97%. There's a factor built in there for bad debt, charity, administrative denials, but if you start seeing your NCR going down, 90, 92, 93 percentile, you may want to start looking at where where there's deductions that are happening to gross charges that are not contractuals. And I kind of break those buckets out into, there's stuff that you can impact and there's stuff that you just can't, right? But at least knowing what you can't, like, if it's not something that could have been avoided, at least it knows that when you run this, you're like, look, we run 93%, but I can explain why. Sequestration, penalties for regulatory stuff, bundled procedures. I mean, there are things out there that are not necessarily coming across in your contractual allowances that would help explain why you're not running at benchmark. One thing I will say on NCR is it gives you a great opportunity to look at how you are taking adjustments in your office. And I will tell you many, many times when I was in the consulting side, and now even as we look at our own client data, is that you find areas where people are taking inappropriate adjustments. I mean, we found a client that was actually writing off all their denials to contractual allowance. So it's hard to, so you sit there and say, hey, I'm running a 98% NCR, but if you're writing off all your denials to contractual allowance, how am I ever going to really tell you what your NCR is? So you have to look at that. And in our analytics solution, we have line item adjustments, so we can see every single adjustment that's being taken across, and we map those adjustments to categories, so we know what's a contractual versus what's not. So we can manage to that number. But it's important to understand who's posting adjustments and how they're posting and what controls do they have in posting. So make sure it's approved by an office manager, right? Make sure it's approved by a provider if it makes sense, right? You got to understand, what's being written off that's not contractual and why. And then I would audit it too. I would definitely plan to audit it to make sure you understand, if it's not a CO45, it's not a contractual allowance code coming across, you got to know why it's being used and how much, and make sure it's being used appropriately. I go back to the denials, right? I mean, if you're writing inappropriate denials off the contractual allowance, you're in a sense hiding it. It may not be intentional, but it's hard to get at that data. Okay, so overall, that's in summary. Measure to improve. It's what we use as a company. We decided a couple years ago that in order to be efficient in the services we deliver for our clients and the technology we develop for our clients that they rely on to manage their revenue cycle, that we have to have objective ways of having discussions about performance, and you remove as much subjectivity as possible. And so, if we measure everything, I mean, we measure call center, we measure support tickets, we measure AR, we measure everything, because at the end of the day, our CEO needs to know on Monday morning how the organization is operating. And so I can't stress enough, like, identify the measures. I gave you 7 here. There's lots more we could talk about, but identify them, figure out how you're going to measure them, standardize the way you measure them, and look at them consistently over time. When they start to move in a direction you don't like, figure out why. Put changes in place, redesign process, reorganize people, look at technology, acquisitions. There might be technologies that you could buy and deploy that will make you more efficient. You may want to outsource some of your services to be more efficient, to make your numbers go where they want to go. But at the end of the day, you got to measure that over time, because just because you fixed a problem once doesn't mean it's not going to come back. Remember, we made a lot of money in the consulting world by coming back and doing the same thing a year later because people weren't measuring to improve. So, at the end of the day, there's lots of stuff that's out there. Definitely make sure you have a dashboard view. You've got to be able to drill down quickly. 15 years ago, this stuff was in Excel. It was hard to update. Today, there's no excuse. There's literally no excuse. There's lots of tools that can sit on top of PMs. We happen to develop our own internally because we knew we had to have information to make better, more informed business decisions for our clients, and making sure our clients could do the same for themselves. So that's it. I'll hand it back to Ashley. I think there might be some questions that are coming in. I hope this was beneficial. We can distribute the presentation to you, you all, so you have it. And I just appreciate the time. Thanks again. I know you all have busy schedules, so I appreciate the 45 minutes.
Okay, so the main question we have received was requesting the materials. So we will be sending out, just like Matt said, we'll send out the slides and the recorded webinar as a follow-up. So if you have any questions, again, please go ahead and submit them in the questions box to the right of your screen. But we did receive a couple. So the first one is, I don't have time to run reports and monitor metrics and keep up with my day job. How can I keep up with all of this? What do others do?
It's a great question. I mean, one of the things that we've done in Metaball is we've actually created a service offering where we actually become the decision support department for our clients. So, we deploy our practice analytics solution. You have access to it when you have time, but you sleep well at night because we're actually monitoring your data. We're monitoring it consistently, and we're bringing things to the surface, when issues arise. So I think that's one thing to think about, is that, is there an opportunity to outsource the analysis, or you hire someone internally to do it as well, but it starts to get expensive depending on the size of your practice. When I was working with large 200-300 employee doc practices, you could staff 3 or 4 people in decision support. If you're less than 10 docs, it's hard. So it may be more economical to outsource the analysis portion. I think the other big thing is mobile. We put a lot of time and energy into our mobile interface. Is you're on the fly, cup of coffee in the morning, you got to be able to, with your thumb, as I say, we're on our iPhones all day long anyways. You got to be able to quickly pull up your key indicators and just make sure everything's in line. And then if they aren't, you have a way to follow up with people internally as to why. So I think mobile on-the-go stuff is important. It's a great question. We get it all the time, especially from the administrators and also from the physicians. They just don't have enough time to really get in and do it. So hopefully that helps a little bit. What else do we got, Ash?
Okay, great. So when looking at old AR and prioritizing what you want to focus on, what metrics do you find provide the most value?
Well, I mean, on the patient side, I mean, I think you have to accept the fact that there's a certain age that it's no longer worth any effort internally to outsource. Sorry, to keep it in house. That you do have to send it out to collection. So I usually will tell folks, within 120 days from that bill date. So when the patient got their first statement, if there's no payment on that visit, there's no payment plan set up, there's no dialogue or communication with the patient going, that you would send that on to a collection agency to try their luck, and then obviously you're writing it off your receivable. So that's really on the patient side. I mean, I think on the insurance side, it's really looking at your open denials. I mean, what we do and our solution is we'll analyze the AR that's got a denial on it and making sure that we're keeping up with the filing statute, making sure that the appeals are being done correctly. I think I would prioritize always based on cash yield. A lot of people will say age is important. Well, age is important, but at the end of the day, if you're going to have to decide between working on a 120-day old account that's going to yield you $1,000 versus a 300-day account that's going to yield you $200, I would stratify, right? So understanding why you have denials that are out there that's preventing the payment from coming in, and prioritizing based on the expected cash yield, and also looking at the type. If you've got to start analyzing denials, because if you have to change behavior on the clinical side or on the administrative side, with how the claims are being billed, then you got to make those changes. Otherwise, you're constantly drinking water from a fire hose. You're never going to get caught up. Payer, sometimes payers, again, it goes back to cash yield. If you're going to spend resources trying to follow up on commercial managed care that could pay you 60, 70 cents on the dollar versus, a Medicaid that's paying you 20, I would take that in consideration. The last thing you want is a denial on the commercial managed care side that you don't overturn because you miss an appeal statute. So if that helps.
Okay, great. I think I've got one more here. We have a challenge collecting from patients while they're in the office, and we don't have a way to do it ahead of time. What are some tools we can look at, and can you recommend some quick fixes?
Yeah, so I mean, and I don't know the demographic of the practice. If you're a specialty practice, non-emergency room, basically, and these patients come in, whether they're Medicare or they're commercial managed care, they know they're going to owe something. Nobody can turn on the news at night anymore or read the newspaper and not know that consumer responsibility is going up in healthcare, period, right? So they know it. They may not want to accept it, but they know it. So one of the things that we've done as a company is we've started to look at pre-collection as a service. So where, you use a good estimator. There's lots of estimators on the market, but be careful. You want to make sure you're doing one that's actually integrating your fee schedules, so it really knows what that patient is going to owe, not just a standard, text string out there saying, well, this is their deductible. I'm not going to tell you how much they've paid year to date. And, you end up over collecting from the patient. You don't want to do that. You need to understand where they're at, and you need to understand the fee schedule and what they're going to owe based on the procedure you're about to do. So use a good estimator. Make sure that you do an outbound call. Do an outbound call to your surgeries first, right? So call those patients. Make it a customer service. Hey, you're coming in for surgery. I want to remind you to do this, this, and this. I'm also going to just double check. This is where you live. This is your address. I already ran your verification of benefits and eligibility. I've already got your pre-cert in place. So you make it kind of a consumer-driven call. By the way, you're going to owe $840. How would you like to pay? And you just start to build that into your regimen. And if they don't have the ability to pay, like, geez, I didn't know it was going to be that much. What are my options? Make sure you have some financial clearance processes in place. Well, we can do a payment plan for you. You pay this much per month over this many months based on the policy, of your organization. Possibly a prompt pay discount. Possibly credit financing, right? There's lots of technologies out there that can match a consumer with credit financing through a mobile text. We're actually talking with some partners right now that are doing it, and we're looking to embed that into our practice management system. So patient engagement is only getting better, and there's cool niche companies out there doing everything from estimation to the eligibility checking, skip tracing, And then obviously, being able to finance these procedures, because remember, at the end of the day, especially in the elective market, patients are still going to need surgeries. I still will have a torn labrum. The difference is I don't have the money to pay you in January. Could I work with you, though, to still get the service so I'm not in pain every day? And you know that you're protected in terms of getting your money for the service you're about to do. So we have to get more consumer focuses in the industry. At the end of the day, we're all consumers ourselves. So hopefully that helps a little bit. I'd be happy to circle up with you, whoever asked the question after the fact, and talk more specifics on technology and vendor names. But great question. Anything out, Ash? Or are we good?
I think that's it for now.
Okay. Well, again, I thank everyone for your time. I appreciate it. We'll make sure to distribute the presentations. If you have follow-up, don't hesitate to reach out. We'd love to talk with you. If you have more specific questions around metrics or other metrics that you all use, I'd be happy to learn about them as well. I mean, we're all in this together, and we all are short on time. So the more transparent we can be with our revenue cycles and using metrics that we all agree to, the better for everyone. So I hope you all have a great rest of your day, and look forward to hearing from you.